Council, and she has co-founded multiple portals for child development, and she has developed apps for monitoring milestones. So those who have been working, the most important thing to understand is that how is the child developing? So this is how the parents' motivation remains, and then everybody's motivation remains as what we are doing for the child. Are we doing the best? And this is what she has developed apps so that you can monitor the milestones and keep tracking their development. And she's been working with the Dolphin. She's got a Dolphin program by the name Smiles program, and she's also got the Todd's Guide program. And she's a recipient of many, many awards, the Ashoka Award and the Manthan Award. And she recently got the Lifetime Award from the Neurodevelopment Chapter of Pediatrics. So I welcome you, Dr. Nandini, and we are all waiting to hear from her about the early detection of autism and its management. Over to you, Nandini.
Good afternoon, everyone. And am I audible?
Yes, ma'am.
Yeah. And thank you, Dr. Sabina, for your kind words, and Dr. Mallikarjun for thinking me to invite for the first lecture other than CP, which is definitely my weak point. And I have learned a lot from the Indian Academy of Cerebral Palsy and interacting with you all for several years. And thank you for giving me that knowledge. And today we're going to talk on autism, which is really a subject which is pretty dear to me. And I want to say, I was just thinking when you sort of only 6.9% of children with CP really have co-gaps at autism. So I was wondering, why do CP people want to listen to autism? And then I realized that he has a bigger vision of getting into childhood disability. And as such, isolated disabilities are so rare. Whether every one of them have an associated disability with the main disability. So, and so does autism. Autism is perhaps the worst among all when you look into comorbidities and associated problems. And it's a very interesting problem, but it's a very challenging issue. And in spite of being 30 years in this field, as I see the neuroscience advancement which is happening, I feel I know less and less of this subject. So it's a lifetime learning for all of us, and any update and knowledge would be absolutely useful, I think. As I want to share my first thought is, this is never a job of one man. Anything to do with disability is to on the slide presentation. Okay, so you have to give me my slides, for talking.
Yes.
So anything to do with disability is always
Now you can share, madam.
Yeah. It's a teamwork. It's a teamwork of multiple partners having multiple roles to play in this issue. It's never a one-man knowledge. And the second thing, my humble request to all the young people is, we have a lot of knowledge, we gather a lot of knowledge, but do we translate that into action? Do we put it into practice? And third, I would request, there are lots of therapies, lots of things that if we all try to work on evidence-based therapies, it will be far more useful to stand in an international forum, and also for us to know what is really, really happening with the children. So with this small introduction of mine, I'm going to start my presentation. And autism itself is, as you all know, it is always always unique, totally intelligent, sometimes mysterious. This is the definition of children with autism, and it is so true that no two children are alike. Every one of them have a different kind of a problem. That is the even more challenging in this field for this. So during this outline, I'm going to talk about briefly about the neurodevelopment, what is the autism spectrum disorder, what is the clinical features, and what is the role of therapists. and pediatrician in the intervention. So let's see, if you look into the epidemiology, you see 4 to 5, 10,000 was in 66. Today, the US and all said 1 in 50. In India, we are seeing 1 in 100. But whatever said and done, we are seeing, all of us are seeing a rise in number of children in autism. Also, all of us are going to face the problem. Any therapist dealing with CP or dealing with children with intellectual disability, everybody is going to see autism in their practice. So the question is the change in definition, is it because of improved case detection or is it true increase? Most of the people think it's a true increase, but nevertheless, there is a debatable point, but that's not important. But definitely, the boys are affected more than the girls, and the ratio of, if you compare it, I put 2.5 of them have severe cognitive dysfunction as 4:1 have normal cognitive dysfunction. So this is important for us to understand. So as you all know, it's a neurodevelopmental disorder. It is characterized by persistent deficit in what? Most important, in social communication and interaction. That is what you have. All the problems in autism stems from this deficiency of social communication and interaction. And they have presence of repetitive, restrictive patterns of behavior, interest, activities, which is the second part. So if you look into the clinical features, which, well, as you all know, we are talking about early intervention. So I'm going to give some ideas of what you should look for below at a very young age to suspect. We don't diagnose autism spectrum below 3 years, but the index of suspicion should be very high, as high. Sometimes people say in 3 months, 4 months, 6 months, even by 12 months, if you see a child who does not respond by 12 months and prefers to play alone, avoids eye contact, does not share interest with others, particularly with parents. See, most children will get very excited. They'll bring a toy, they'll show it to their parents, or they'll say, "Okay, mama, bobo," they get, all this starts below 1 year. If these features are not present, you will have to understand what is it. And their interaction sometimes is very need-based for their own goal. They will go and point if they want something, or they really don't have others in mind. Very flat expression on their faces, and avoids sometimes they avoid physical contact, not comfortable by others. They don't like to go out. They don't like others coming, and have difficulty in understanding feelings of others. If you see communication, I want to spend 1 minute here. Communication is not delayed speech or language. Many of them have, all of them, because they don't socially interact, they also, I feel, communication is delayed. Why don't you communicate? You have to have a social interaction to communicate. If you see me walking on the road, we don't talk to every person walking on the road. Some connection is made in life for us to socially connect, and then you communicate. It is not just delayed speech. Speech has nothing to do with language. Speech is all due to with oral apparatus and pronunciations and stuttering, stammering, but language is everything to do with what we do. So one of the greatest mistakes therapists make, doctors make, when the child comes to you, they say, yes, he can say ABCD. He says 1, 2, 3, 4. He knows the rhymes. He repeats the rhymes. He also knows what I say. He repeats it again. Is that language? What is the purpose of a language? A purpose of a language for us is not just to express any need-based, but to communicate our ideas, our desires, our emotions. That's what we use language for. It can be written expression, it can be oral expression, it can be any form of, but language is when a child, that's why when a child shares a joy, we say, Mama, he's expressing his desire. If he wants to point, says, I want to go there, I want to bring that. He's expressing his need. So please be very, very careful. Just by a rote memory, if the child says a few poems and repeats alphabets, that is really not language. So they use very few gestures, may use some, what should I say, some culturally gestures like bye-bye, good, but they will not use gestures for pointing, asking, showing, and they may repeat phrases over and over again. That's called echolalia. If you see they play, the play is a great way of understanding children. The so-called imitative play, when the child is very young, to imitate the parents. I'll come to you about that. When they're 2 years or so, they'll imitate the parents, pretending to talk on the phone, sweeping the house. By the time they come to 3, they'll pretend They will feeding the doll. They will have so many, as they grow older, we will not be able to use pronouns. They will give unrelated answers to questions. And these are, as they grow older, they're so literal in their meanings that we say it's raining cats and dogs, they'll go outside and say cats and dogs are falling. There's a very popular say, they do not understand jokes, sarcasm, teasing, etc. The unusual interest they have, they may line up toys, they may play the toy the same way every time. They would like to see the part of an object and a whole of an object. They have the same preferred sameness. Many people tell you they like to go by the same route to the school. If you change it, they'll get upset. Even minor changes, they get upset. Some of them have very obsessive interests and they flap hand, rocking Bobby. All these are sensory issues. So this is what affects them. The sensory issues, the delayed in social interaction, communication is what is and many of them maybe have associated fractures, that they are very active, they're impulsive, very short aggressive span. Many of them have many behavioral problems, sleeping problem, eating problem, mood disorders, fear. All these can be other associated things with the core symptoms of autism. So that's not the topic for today, so I'm just going to rush through this. So second part we'll talk about is a restrictive repetitive behavior. We said that the behavior of interest, there are two of them, at least two of the following should be present. One is insistence of the sameness, inflexibility or routine or ritualization, or highly restrictive, fixated interests or abnormal interests, or hypoactivity to the sensory stimuli. So these are the diagnostic, the DSM-5 criteria. Symptoms must be present from the early childhood, from the very childhood stage, and they are clinically significant in social occupation, important for current functioning of the child. These disturbances are not explained by intellectual disability or global developmental delay. You have to understand the restrictive features, the unusual echolalia, or all sensory issues are not generally the features of the global developmental delay. I'm sorry, I think this slide got a little skipped. So we have that according to DSM-5, you should have criteria: deficit in social communication, reciprocity, non-verbal communication, behavior used for social interaction, deficit in maintaining understanding relationship. Now let's go on to, that's a brief introduction for what autism is, which I think all of you knew, but I just quickly revise it. What do we have to know when you're planning about therapy? So this developmental disorder is problem in the neural pathways. It starts from antenatal period. It has problem in forming synapses and pruning, and it is measured by attending the developmental milestones at different ages. So if you understand this in mind, we have to know what is the synaptic pruning. And if you look into the brain of the child, number of neurons which you have, maybe 1 trillion of them is fixed most of the time. Very rarely neurogenesis occurs. But what happens during our growth and development from infancy to adulthood is that we have the connection between these nerve cells, which is called synapses, develops between these cells. These synapses develop in very, very, very rapidly in the first 2 years of life, and then it's little slow down by 3 years. And by 5 years, we have almost 80 to 90% of synapses which develop. This is called neuroplasticity. I want you to get a picture of there are several types of neuroplasticity. This is called developmental neuroplasticity. That means in developmental neuroplasticity, you're laying foundation for the first time. There are other issues when you have other neuroplasticity, like, for example, the person who has a stroke in the adulthood loses all his faculties. He can come back. He learns to speak. He learns to walk. That is a different kind of a neuroplasticity. Here, if you don't lay the foundation itself, you are at a bigger loss. That's why developmental neuroplasticity is very, very important for you all to understand. Now, what happens to this brain, the brain which makes synapses, grows very haphazardly. It will go for everything the child does, which I'm going to tell you now. But over a period of time, what you use, you will keep. What you don't use, you will lose. So the principles of neuroplasticity itself is use it or grow it, or use it or lose it. So, this is the one next slide. Sorry, I'm skipping some slide. Saraswati, how do I go back? No, I want to go back to, no. Sorry. I just go back to the slide. So we have use it or no. Go back to go back to that. So we keep go back. Yeah. So this is fun. So what we don't, so what is important for you to realize is there's a very nice saying in our own country, in my own, I'm a Tamilian from South, and I quote this very, my mother, who's 97, I'm almost 75, used to tell me then, Anjila varadu, Ambadala varadu. Means in Tamil, it means what you don't learn at 5, you will not learn at 50. And we used to laugh at her. And many times when we did something wrong, we used to keep telling her, you didn't teach me when I was 5, so how will I know it? It's a big joke. But it's only when I started doing child development, did some workshop with Dr. Greenspan, and he said the same thing. What you don't learn at 5, you don't learn at 50. I said, oh my God. Then my eyes opened to say, wasn't the wisdom in our culture of development of what it is, but we knew early intervention many years ago. But what is important for us is 90% of brain development happens below 5 years. And you could see the sequence, which is important. What happens in very early childhood? First thing to develop it, sensory skills. Auditory, you just see auditory starts even before birth. Vision, attachment. We don't pay any importance to this. And this really dictates our life throughout our life, even in adulthood. Attachment, vision. And then we have intellectual development is last to start. Peer and social later, but initial attachment, bonding, and social interaction starts very early in life. So the sensory development occurs first, then comes the language. Intellectual really comes later. But we have to know that this is very important. And this is a timeline. The maximum neuroplasticity helps you to develop this early. And if you lose this time, you have lost out on this child. So this chart tells you that time is essence of your diagnosis and in your intervention. That is sensory first, motor language, higher cognitive function later. Why do we insist on this in our country all the time? School. When the child doesn't have any idea of why do I click? Well, so next I'm going to tell you something very interesting. So you see, this is the development. So I mean, spending time on this to understand the neuroplasticity as it's happening, as you see, and it will wean off if you don't use this. This curve tells you what is the importance of early intervention and what should be the emphasis on early intervention. At what age should you be doing what? Okay. Now I'm going to come to the second part of very interesting things which are happening in child development, neuropsychology, neurosciences, is that we have a two mind, what is called the conscious mind and the subconscious mind. Each one of us, you and me also, hardly use 5% of what we think and do, which is coming from the prefrontal cortex, which is thinking brain, as we call it, time management, problem solving. So this is all we think. Listening to this webinar, for example, is coming from your. That conscious mind has a very short memory. It helps in critical thinking, logical thinking, willpower is 5%. But 95% is your unlimited potential in the subconscious mind, which is for what? Imagination, your belief. I tell my parent, why do you believe your child can't do this? This belief is not true. It may change tomorrow. Our parents come. Why this is important? I'll tell you why we work so much with subconscious mind all the time in my center. Habit formation. You have a habit. It's so difficult because emotional values, protective reaction, intuitions, and long-term memory. All these are in your subconscious mind. Subconscious mind is not a thinking mind. It is an automatic mind. It'll just give you the input. It doesn't say, oh, this is, I have to do this at that time. No. Why is this important for you? You're important because below 4 to 5 years, the child does not have a conscious mind. It is all the time being programmed in the subconscious mind, which is also called the hypnotic mind, or whatever you all want to call it. This is programmed by whom? By the adults around it. The baby can't think. Who is thinking for us? We, the therapists, the parents, the schools. That poor child is the victim of what programs we put into the brain. It's like the baby is born like a computer with no program in it. If I give you a gift, you'll say, what is this, doctor? There's no Google, there's no Microsoft, there is no PowerPoint. I can't use this. So put all these programs. This program in a baby, in a young child, is put by us. The child just executes it on what he has learned from us all the time. So anything when a child doesn't do, when we are punitive, we are yelling at it, hitting, therapists, I have had therapists who I threw them out of my job because they would hit the child, pinch the child because it's not performing, or we say punish it, he will do, give him 2 whacks, he will do it. What can he do? You have not taught him what to do, or you have not. You can't teach. I tell you how the subconscious mind learns also. It's very interesting. So understand that below 5 years, we are the programming for the child. And what happens in the subconscious mind is, why is it second thing for you to understand it? It gets automated. It becomes automatically, it will react. It doesn't think. I told you, it doesn't have thinking capacity. That is why many things, when it's get automated, it's very important for us. For example, you have learned to walk when you're 1.5 years. Do you think every time you get up, oh, I have to get up to walk? No, you start doing automatic because it just gives you the brain is automated. Same thing, if you learn anything by experience, it will be automated in your subconscious mind. For example, you learn how to cycle. If I don't cycle for 10 years also, if I give you a cycle, you will cycle because it's there. It can. But you have learned algebra, you have learned geometry and trigonometry, sine theta, cos theta, and blah theta, what theta, I don't know. If I ask you one formula from this, you'll say, I don't know. Because you learned it for knowledge. It was others' brain which taught you. And since you're not using it, you've forgotten it also. So you have to remember. So you have to automate the subconscious mind. How does automate comes? One is by experience. When you do experiential learning, it sits there. Second thing, you have to practice. If you don't practice, it goes away. Take a violin and start playing. You can't. You will have to practice it hundreds of times to get that one string, this thing. So that is the power of your unconscious mind. And unconscious mind rules us, all of us, all the time. So what you see in the top of a thing is only 5%. For example, you see an angry child. That angry child which you see, it has got so many reasons behind it. It can be an emotional reason, it can be hunger, it can be a subconscious mind of fear, it can be lack of attention because he doesn't know how to communicate, he's in insecure state, he's just deregulating and crying for help. Help me. But what we deal with is that anger or that child hitting, beating, throwing tantrum, not understanding. That's not what, he has no other way. He has seen us yelling and screaming, and so probably he learned this is the best way to express anger. But he cannot think in the subconscious mind. So please remember this very much when you do a. Then we understand some facts about development is, you have to know it's orderly, timed, and sequential. Why am I saying timed? When your brain does not wait for us. It says, no, I finished 2 years, I've started you get delayed, it's a problem, you will be delayed, So the timely intervention. So this wait and watch, which we all do, is the worst thing we can do to a child, whether it is the elders in the house, therapists, even sometimes doctors, and say, no, he'll be all right. Don't say he'll be all right. Check on it. I'm not saying every time there is a delay, there is a problem, but you cannot leave it. And it is orderly, sequential. And occurs with regularity and predictable. Because it occurs with regularity and predictable, we have milestones. We know a child who is not walking, say by 2 years, it's delayed. We know a child who is not saying the first word by 18 months because it is predictable. But do we know how to use it, predictability, and act on it is a question. Then all streams of development, that they're the 4 streams, physical, communication, cognitive, all of them develop abreast. That means they're more or less at the same time, they're related and overlap. And there's a reliable way of tracking them. And as a pediatrician, I always say on your well baby clinic or when the child comes to you for whatever therapy, if not this language, please ask about the other siblings who are coming. As a therapist, you may be dealing with the affected child, but you may also have the parent having another child whom you could be very, very beneficial by giving these ideas to them that please monitor. And also what happens is, what is not visible, what you cannot see, your mind does not learn. Language, social cognition are easily missed because, first of all, they're not obvious. You have to ask about them. They're not so visible like the physical. A child does not walk away 12, 15 months, parents will go running to the doctor. But they don't care whether social cognition language does not come because they're called hidden milestones. And you have to ask about it specifically. So these are the 4 domains of development which I talked about for the whole child. Social emotional blends with adaptive communication. They overlap, as I told you, they're not cognitive. This is just to reiterate that point that you have to monitor milestones. So this is a very nice chart. You can download this, available. It gives you social milestones, which I told you is my sore point all the time, that these, I have circled these social milestones for you all, which you must know at every age. This is what you miss the most. Communication language, you again pick up a little, but you don't monitor my social milestones, and that is very, very distressing. So these are some of the social milestones, like prefers parents' voice and smiles spontaneously by 4 months, recognizes familiar faces, notices strangers. These are all, this is all available in the book. So nothing, I just put out a few of them to show what is it you should be looking for. Stranger anxiety, playing peekaboo, waving bye-bye. In our culture, I want to emphasize again and again, I'm very, very fond of the Indian culture and I adapt everything. How many games we have for our young children? We do Taramaya, we do, so many games you sing, and you always say, this fingers, you say it in English, but there are lots of things like who went for a walk, and we have this, it's you talk, but we also have these tickling games. Every language has it. I can tell you in Tamil, but it's of no use. But I know my language, all the games. So this is very important. It's very easy to tell the parents to watch out for this. And even in your training, I use this very, very often to tell them that is, and very important is for using gestures to point, proto-imperative point. The child, at least by 12 months, must put his hand out and point to what he wants. Please ask about it, And by 15 to 18 months, he'll point and look back, also saying non-verbally communicating, that's what I want, for the. Now, having said this, I've said it till 15 months, because if you do this, everyone should monitor. Here is what is important in I'm going to say 2 minutes on attachment bonding. What is attachment bonding? Attachment bonding is a child, when it's born, comes with a neural circuit for mental development with 4 things. It believes when it is born that the caregiver who takes care of me will look after me. They will keep me safe. They'll soothe me when I'm distressed. They will see me. See me means they don't see visually. See me means they will know me. I'm crying for milk now. I'm hungry now, or I want a diaper change. My mother will know this. And she bonds. And when the child, we do what the child is in the mind, the child feels very secured and has a very beautiful relationship with the mother. And I'm sorry, the mother is usually the caregiver, but this can be anyone. It can be the grandmother, it can be the father, whoever is taking care. This secured attachment is very essential for a child's mental development. So what is insecure attachment, you'll ask me? Insecurity is when the baby does not feel this. Sometimes a mother who's in depression after postpartum, the child is crying loudly, please help me. Nobody is going. And the child then goes to believe that I am alone in this world. There's nobody to look after me, and becomes one of the big narcissists. All these people, they have no emotional attachment. This is a big topic by itself. I love to talk on this sometime, but just to tell you, if a child is attached to a parent, they have very good interaction. They express their interest in social interaction, pay attention, share emotions with this thing. You can do this as early as 4 months. Comes out of this is imitation in the very early age. Motor imitation, I just told you about gross motor imitation, fine motor imitation, oral imitations, verbal imitations. These are the various kinds of imitation which comes in the first year of life, which all of you as therapists must be very aware, because this is important even in your therapy. So when you have a very secure child, you have a very building sustainable relationship, You're very good at sharing when the child comes. You will enjoy conversation. When I say it can be non-verbal, verbal, you understand humor. You show concerns to others. This compassion, so beautiful. Dr. Mallikarjun was talking about compassion and empathy, which we have to show to receive it from our children. And of course, building a sustainable relationship and receiving and giving compliments. These are all the skills which you need to develop in children, which happens in a secure. So when you're sitting after going to this, I'm going to now go on to the intervention part. I just wanted to say this is the basis for all this. When you have to do an intervention, you have to know a good assessment in understanding the areas in which child uses to learn. What are they? One is receptive language and understanding language, expressive language. Expressive language is both for communication for functional needs as well as social communication, expressive. Third is imitation skills. Imitation skills are poor. You can be rest assured language is going to come very slowly. Peer interaction to play, learn, and grow together is so important. Fine motor skills, you're all very good at. Intelligence and play. These are called the learning constructs. Each of these areas you have to plan a program in intervention if you're really taking care of the child. So if you see the social framework of this autism, it's just not social impairment, speech, repetitive. On this framework, you have your language disorder, you have intellectual disorder, but you see what are all happening to this child. They have as comorbidity, social anxiety, OCD, ADHD, aggression. So this makes the autism a very complicated subject to manage. So if you want to have a good program for intervention, you must have a basic good assessment tool. Assessment to diagnose. In our center, we of course we're all trained in ADOS because infant toddler ADOS tells you, it gives you severity of what could happen. Is a child moderately or mildly, so that you can do. We use the early learning or whatever intellectual scale you are using it to determine the early learning or IQ. You have to know what are the adaptive function of the skill and the social skills which are important. And we also do the behavioral profile. Not that we do every test on the child, but these are the tests which we use. So when you're planning to ask a question and intervention, you have to ask the following questions. What is the main issue? How do I address this? Why do I address this? When is it to be done? And who will do this? I told you it's a teamwork. So these questions I ask even today to myself, then plan an intervention. So what should be the focus of intervention? You have to start a functional development. We also have to take care of all the 5F, which you're all very familiar. I'm coming to that later. But on the child for intervention purposes, I'm talking the other topics I'll be coming. You have to know what is the functional development of the child. If you're planning a program, what have you got for you to find out on the follow-up? When are you going to see? And what improvement you're going to see? How much are you going to see? Does a child have behavioral problems which you have to have? What is a social emotional program you will be thinking? And what are the strategy you will have for comorbidities? That is why this cannot be done by one person. You have to have a team of people who plan this. And we on our center always work. Each one member is an important team member. So while you're planning this, there are many programs which aid and improved by this thing. You have lots of alternatives like music, art, sports, technology, parent participation, parent wellness, sibling program. All this comes in your other file. But we only talked about function. You have friends, family, focus. All this is what you are planning for the holistic management of the child with autism. In our center, we have developed a program called the Scope Profile, which we use for assessment, which is a patented program where you see this column. It has got 3. This is used for children between 6 months to 5 years. This 6 to 18 months, 18 months to 3 years, 3 to 5 years. These are the domains which I told you: receptive language, express language, functional behavioral assessment, play, peer interaction, self-help skills, cognitive skills, imitation, and fine motor. We have a tool. This is developed based on the zones of proximal development milestones. It took us 3 years to do all this, and done by a core team after a lot of interaction, lot of planning. Green means a child can do this task 100%. He knows it. Orange means it's emerging, and white means he cannot do. Now, this child may be, how old is this child? Some 5 years or something. You can see he's hardly functioning at 1.5 year level. He has a scatter. He has some rule-based behavior, some fine motor skills, but look at his language. So you can make this out. So this, and when you plan a program for this child, we will plan it for wherever the areas of this also is automated and comes to us. So a score profile will come to you like something like this, their expressive language, whatever, this age is 5 years, but his receptive language is only between 10 to 12 months, his play is only between, expressive is only 14 to 16 months, play is between 14 to 16. There's the same report, which we give it to every parent, anyone, and we train people on this. If any of you are interested, I'll be very happy to help you to train. So this is how the report goes, and this is how, now what happens based on that, we have a software which gives the activity to the parents. So what are the activities will come that you have to do such and such activity. And then we also have something called EDIT training. EDIT means educating parents on direct and interfering training technique. This is a program, how to, that first the parents are trained how to become, first of all, a parent who are interactive. You're an interactive parent first. Interactive, if you don't have interaction with the child, you cannot do training, teaching. But means the minimum mental age of the child should be at least beyond 1.5 years for you to start giving some formal training, like put the block, blah, blah, whichever you want to do. So this EDIT training we give for every activity. What is the technique you should use? So this is a very comprehensive tool which you have. See this child after 1 year, the same child after therapy, I think he was there for about 9 months to 1 year. He was here. He is almost done. So well he improves. If you program, because the software monitors itself, only when a task is achieved will they go to the next. So why I'm showing you this is you should have a tool which gives you progress. Now we still know we have to still work with play with this child, which is behind. You see, cognitively he has caught up quite well. He's doing maths, English. But look at his peer interaction. Look at his play. It's hardly as good as, say, 2 years plus. See this play. See this communication. But because his this verbal VPS means visual perceptual reaction, visual perceptual skills in young children monitor cognition. Because that is good, his skills is good here. But we have a great hope he will improve this, because when cognition is good, we have a great chance of improving this. So we worked in this child mainly on his imitation skills. We are still continuing to work with them. He's 5 years plus, and the child is doing pretty well. So the model which we have developed is because it's called the Naturalistic Development Behavioral Intervention Model. That is the NDBI model, which we find works the best because it focuses on the natural atmosphere. That is, it is parent mediated at home. During daily routine and activity, the child does all the program with his parent during bathing, eating, playing, dressing, etc. Teaching developmentally appropriate skills and activities based on his level. We use all the behavioral ABA techniques like breaking down the skills. We use rewards and reinforcers. We ask them to master the skill of the child. As I told you, in the subconscious mind, you need 3 things. I told you 2. I told you experience and I told you practice. Third thing is called affirmation. Affirmation is positive affirmation. Not telling the child good guy, bad boy or thing. Just you're trying. Oh, you've done this well. Come on, one more block. You know, when they have to have that modulation in your voice, your activity, your interest. You're looking at the child should feel this is a friend who's here, who's helping me. He's not here to get her or his agenda fulfilled of doing a task. So that is the 3 things which you need. And a young child, you have to use these techniques to monitor the subconscious mind. Okay, these are some activities and material which from the program which we have. So the advantage of the NDBI model is that it says a child requires 25 hours of therapy a week. How? I don't think in my center, in a city like Bangalore, which is a pretty good center, in terms of income that the child has this to come. Best done by child's home environment. You have to develop very parent friendly, and it must be based on day-to-day activities for empowering the mind. Why? You have to plan an intervention beyond later on for inclusive education, vocational training, complex behavioral problem. All these things you have to plan at this thing. So when you want a better functioning, you have to have a program, which I told you in the beginning, parent wellness, parent activity. Parent wellness is utmost important. 60 to 70% of the parents have anxiety, depression with a child with. If I have that, I cannot be sitting and giving this lecture to you here. I cannot work well. Fear, their insecurity. We have a program called Acceptance Commitment Theory, a parent wellness program. We run this online. It's 6 weeks program. We have trained many centers. You have to imbibe this. We have to tell, you have to have a parent well-being program. It is at most giving an activity of all this is only 30 to 40% of the child's improvement. 60 to 70% is how is the child accepted by the society, by the people. That is the most important. You have to have that in position. If you don't work with the parents, however good therapist, however good doctor we are, we really will, the child cannot attain his full potential. So having a parent well-being program, which is a beautiful program, we developed it with the help of the Canadians. It's called based on acceptance commitment theory, is one of the psychological theory which acts on this. All of you can go to, it's called ACT. And based on that, we have a 6 or 8, 7 weeks module every Saturday for 1.5 to 2 hours. Is an online. Anybody who is interested, it's very cheap, doesn't cost more than 2,000 or 2,500 to be enrolled for the whole program. We do the observers course, we do the trainers course, we do training the trainers, and we want many centers to take it up. We have put in some hard work, and all my therapists have to undergo these kind of trainings, and we have worked on that. So beyond intervention for early, you have, when you're doing intervention, what are you? You're planning for an inclusive education. Are you planning for a vocational training? Are you planning for a complexity of behavioral problem, a suitable counseling, medication? All this you have to keep in mind as a therapist. So what happens after 6 years, 7 years? What's a lot? Is if child has got severe mental, say, intellectual disability along with autism, what's your line? If the child is mild, what is your line? Because you will find that when you have very high functioning autism kids, I don't know where that's one slide gone, you have to think of the social emotional program. See, there are many children in your schools who are there, they go to do quite well in their academics. Where they are failing is they don't have friends, they don't know how to. A social thinking program, we have just established a social thinking where you have to teach the child how to think from your all the senses, how to body in the group, and how do you understand emotions, and you have to. Social thinking is very important for especially high functioning autism children, because they all go to normal schools and they'll come to you. For example, they come to my center for, so this is about, I think, say 16 weeks or 12 weeks, we have training program, and we empower them with this along with the parents. The second thing, is this complete? What happens to the sibling? We have just added this year the sibling program. All the siblings of autism are neglected. They don't get their full potential because they think the parents spend all their money, effort looking after the only child with this thing, and they are told you're grown up, you can do it yourself. Do you know how much of trauma they undergo, how much of problem they have? So you must have a sibling well-being program, parent well-being program. So inclusive education, you've got to work with the schools and teachers. For heaven's sake, my humblest request to all of you is, do not recommend a shadow teacher. If the child has to experience and learn, shadow teacher just keeps the child quiet in the class or does something. Is the child benefiting out of that? Is the child learning? Rather, it comes to you for therapy. Don't recommend school before the child is ready for school. 1.5 brain year child sits, though he may be 5 years age. If he goes to school, how much of trauma can he speak? Can he do? Even somebody pushes the child, he doesn't know how to ask for help. So much of fear. So when the child is ready to learn, when you have the program for him, much better than early learning, which is not beneficial to these children. And many of the behavioral problem on later on years, which are, now these children are living beyond early intervention to adulthood, adolescent. We are facing a lot of problems only because we have, what should I say, no, I think I'm going backwards or I'm going forward. Okay. So now I'm going to, the function of ASD is strongly, it is related to cognition. If the cognition is good, you can work very well as a therapist. It gives you better play. A child with communication, without communication, appropriate toy play by 5 years, you should really, really wonder and start preparing the parents for the future of this child. Studies shows that low percentage of employment and independent living with these kind of children, but early intervention and early diagnosis is absolutely crucial for the future management of the child. I would like to say that the World Autism Day happens. So all you cerebral palsy people are joining us on the autism. So go blue on April 2nd, celebrate autism awareness, and please help these children to your best ability, because they are in utter need, not just their family, and everybody needs you to support them to help for these children to live a better living. Thank you very much for giving this opportunity for me to speak on this subject.
Yes, thank you, Nandini, for the wonderful presentation. And it was very lucid, and you have opened up the subject beyond looking at the child's behavior, the hidden milestones that we generally forget, the social milestones, the language milestones, the communication milestones, the emotional milestones, that this is what needs to be really looked into. So I will just like to summarize quickly. One is, I like the way you've said that disability is never to be considered as an isolated disability. So this is one thing everyone should remember, that disability is, especially with autism coming and delayed language, delayed communication, delayed speech, learning disorders, all these, it's a continuum. It's a continuum. And hence, once we see a child, we have to see not the only single problem, but we have to look at the child holistically. And another thing that she has pointed out is about that you have to understand that this child is going to change over time. And hence, you will find that what she was today, with the little stimulation that has been done, she will improve. But the fact is that internal development is going on, and then we have to remember to keep the child at pace with the activities that we are providing, and to try to keep the development, because new behaviors are going to emerge, and all that needs to be, the parent has to be prepared about understanding that is going to happen to the child as the child keeps growing up. Next is, she talked about the collaborative work. Yes, it is a collaborative work. But one thing which I want to say here is, ultimately, when the management came, she talked, basically, it is the parents who, it's a parent-mediated management, which is going to really work on the child. Because we have to think now, 1 in 58, 1 in 38 children are deviating. And then, do we have the capacity for 1:1 stimulation? We do not have. There are, I think in RCI registered, we have 1.5 lakhs of special educators to 1 crore. So now we have to think of different strategies of developing workforces by which we are going to now handle the problem. The specialists are always there. Their directions will always be required, but each one of us must develop a workforce around the child so that we can continue and take over what are your instructions have been given, that needs to be taken over. So this is what we have to remember. We should not have barriers and small jackets of pockets of work. It is that we must understand that this child, as Dr. Nandini said, that this child is having a problem. It is not the symptoms that we are going to reach the deficits at this moment. We have to think of the child 10 years ahead. And hence, we have to have this cooperation with all the others who will be in contact with the child. Now, autism, as it's a behaviorally defined problem, And so there will be some behavioral excesses and there will be behavioral deficits. And in the domains of social emotional. So it is not about a child behaving differently. It is about how the child is expressing the needs. And then, as it has been very aptly said, that you have to take behavior as an iceberg, that you see only the tip, and there is so much that the child has to see. So this is the mind that you have to have this open, that he's not listening to me, he is shouting, he is screaming, he's shutting off his eyes. These are not the problems. We have to understand beyond the behavior that what is his need? What is his need? What is the function of this behavior? And this is how exactly, if you address this, you'll be able to take them forward. And Nandini aptly talked about neuroplasticity. We all know, I think Dr. Shashikala has been talking so much on neuroplasticity, but the developmental neuroplasticity is what the habilitation and rehabilitation. This is what Dr. Nandini has aptly taken out, that the initial developmental plan has to be set into this child. So rehabilitation is something that the child has achieved, and then you rehabilitate. But habilitation is something that the developmental plan. So this is where we need to be very, very careful. And this is why we need a multi-disciplinary understanding of the child, so that we lay out the plan for the child. And next is, of course, she talked about, if we talk of neuroplasticity, we have to talk about window periods. So window period is less than 5. And we must know the brain curves, what you stimulate first and what you stimulate second and what you stimulate third. They all go together hand in hand, but the emphasis of stimulation is what we need to give. Okay, so it's been very well said about the conscious and the subconscious. So this is what we really need to work on the child. And then she talked about 2 very nice things, attachment and imitation. These 2 things have been very well. We have no, because we see a child is not socially and emotionally having deficits, but actually the child is having some degree of attachment problem. So that is the root cause. But then again, in the normal psychological terms, also you cannot explain the attachment problem in autism. But yet, this is something that you need to remember, that attachment problem needs to act. Okay, so I think you have laid very well the basis of intervention and 6 F's to be kept in mind, and your scope profile, by which you can see a visual representation of the development. And you have very well spoken about the NDPI program. So I really don't have any questions to ask you. I think I'll leave it to the participants. If they have any questions, we can answer. Any questions? Okay, most of them are, I think, related to.
Madam. This is Vishwanath. Actually, I'm working as a special educator in inclusive schools. Actually, I have a doubt regarding the autism. Is there any possibility to get a genetical effect? Is there any chance to get autism through genetical version like that? Is there any chance?
No, I didn't understand. Any genetic disorders giving rise to autism?
No. I'm asking. Just is there any chance to get autism through genetical?
Oh, you mean, can it go from family to family?
Yeah.
Yes, the chances are minimal, but yes. If you have identical twins, I think it is 4%, I think, or 2%. Sabina, I don't know, but it's like that. But otherwise, if it is identical twins, then the chances are very high. If they are non-identical twins, then it is slightly less, and there are 2 different siblings, that's even less. But it is possible, higher than the general population, but very low risk.
And 5 to 7%, you might have
one-
chances.
Yeah,
Yeah,
I'm sorry, I don't remember.
One more question. One more. Like a chromosome effect, is there any like that?
No, you can't do a chromosomal assay and find out autism. This has to be
Okay.
some exome, genome. It's a very difficult. As such, I have this talk. I have a full genetic talk on autism, which genes, what, where, which loci. I prepared this talk because till last night I thought I was talking to the pediatrician. So I had but this morning I came, and then last night Dr. Mallikarjun, said the therapist, 90% of them. So I really changed my whole talk this morning to gearing towards the practical aspects of what is the lacunae which is happening in our country on therapists. So there is no specific gene we know as yet. Since we don't know a specific gene, it's very difficult to find out. That is not at all important in autism. That's what I feel.
Okay.
Even as we practicing at this level, hardly ever do genetic testing unless we find phenotype. We have to do 3-generation family tree, and then we find out what other neurological disorders. Then we look into this child for dysmorphism somewhere and then refer them for a genetic testing. But that's really, the second thing is, if this is the index child, the last child, or the parents are not going to have any other children, then this becomes even more irrelevant, to tell. And they're very expensive. They rather spend their money on therapies and stuff like that, rather than going for genetic testing.
Okay.
I
Thank you.
hope you
madam.
answered
Thank
the
you.
question to some extent.
No, it's good, madam. Good presentation. Actually, I got more knowledge from your presentation. madam.
Thank you so
very
much for
Thank you.
sharing that.
Any other questions?
Hello, ma'am. Am I
Yeah.
audible?
Yeah.
Yeah.
Ma'am, during the lecture, you said ki if anybody is interested to learn
Yeah.
the things you spoke about, so I
Yeah.
would like to know more about the courses.
What I will do is, Dr.
training.
Mallikarjun, I know from periodic when I do training, I'll send these programs to you. You can pass it on. We don't do it every time, but we do. For example, many people, pediatricians are also asking it for 8 weeks. We do it on Saturdays, 1.5 hours, So, and we also have, for one week, you also put up the recording if the parents are not able, if the particular person is not able, then we first do an observers. Then we do, if you're interested to be a trainer, you have to do homework. It's a very good, I think every therapist must do a program for parent well-being. Believe me, if the parents are on board with you, it's skyrocketing improvement you see in children, because their anxiety, their fear, they cannot work with the child. Those thoughts come and block even us. When we are fear of the exam, we know the question, we don't answer and come. Is the same thing. Please, I'll put this up, and I'm sure if you're kind enough to send it to your members, so anyone who's interested can join. Is that all right? Will that help you?
Okay, madam. We'll do that.
Yeah.
We'll do that. Madam, one Rashmi Desai wanted to know that, I don't know, is this a question or not? A child may have challenge with communication by 5 years, but prognosis can never be poor.
But child may have poor prognosis by 5 years. What is the
child may have challenge with communication by 5 years.
So there are many factors which goes into communication. Communication, as I told you, is not need-based, not academics. Social communication is what I am talking about. Have a look. Even I have children, what is poor? They may do well in school. They may be able to do good cognition. If they have good intelligence, then they will do quite well in their classroom. But I have just now a 16-year-old parent coming to me, says my child is doing very well in class. He comes second or third. But doctor, he doesn't have a single friend. Give me somewhere where I can want him to make friends. It will be your social skills which will let you down. They become loners. Many of them are very good in software, professional engineers, because they sit in the front of the computer and work, but their marriages will fail. They communicate. There are lots of implications on this. When I talk about communication, it is social communication. So that is why we have started this program called social thinking. How do they be in the group? How do you understand the emotions of others? Human beings are socially wired. We are wired from evolution to be a social creature. We have parents, father, mother, brother, sister, milkmaid, this thing, maid, school, teacher. You can imagine the number of people we interact with, and with each one of them, we have a different relationship. This is what fails our children with autism when they're cognitively good. That communication is what is most worrying.
And
In no way, I'm not saying that they cannot make a living or not be successful. That was not my idea at all. I'm telling you, I wrote also, if cognition is good, they may do quite well.
one parent wanted to know, madam, these days parents give mobile early to infants and children. Can it contribute to development of autism?
Yes, because I was see, we just talked about importance of wiring in the brain and all that. The social wiring you're taking away from the child because by not interacting with the child, the whole wiring which is happening in the social sector. When you give a mobile to a child is the master of that mobile. What it sees, how it sees, why it sees, you don't know what's in the mind of the child. You may say, I have put poems. He only sees ABCs. He only sees rhymes. But he may not be seeing the rhyme. He may be seeing some blue flickering light there, or something else. We don't know. And above that, forget that. He is the master of that mobile. You are taking away a social wiring. That is why below 2 years, it's not recommended to give a screen time to a child at all during this high phase of this rapid 10,000 connection happening every minute in that neuroplastic brain in the first 2 years. If you're taking this precious time away for social wiring, I think we're doing injustice to that child, no?
Yeah. Thank you very much, madam. And I think you're a wonderful lecture. And I am receiving in my mobile so many WhatsApp chats are there. I was browsing it, and they were thanking us for organizing such a wonderful webinar on autism with a stalwart in the field. And I request our Asha Chitnis to give depth thanks on behalf of Indian Academy of Cerebral Palsy.
Thank you, sir. I think so. On behalf of the President, Secretary, sir, the entire EB and my board of directors, I thank Sabina ma'am and Nandini ma'am for such a nice moderation and a very good lecture. And I thank all the participants who were there right through. And there were many people watching on the Facebook. We will have many webinars as we go ahead. And please be tuned in to IACP Facebook. And once again, a great weekend to all of you. And thank you, Sabina ma'am and Nandini ma'am. Thank you so much.
Thank you. Thank you very much.
Thank you, madam. Thank you, madam.
Thank you,
Sabina,
everyone.
madam.
And have a
Thank you,
great
Nandini,
festival.
madam.
Wish you all
Very
happy
nice.
Dashara.
Yes,
And a
same
wonderful
to you.
time, Sabina, to you, particularly, my dear friend. And sir, thank you very much for this opportunity. I really enjoyed delivering.
Thank you, madam, for accepting our invitation
Thank
and
you.
sparing your valuable time.
Yeah.
Thank you.
My pleasure.
Thank you very
Thank
much.
you.
Thank you, everybody.
Thank you.
Bye-bye.
Thank you. Good
Bye-bye.
Bye-bye.
Bye.
Bye-bye.
Thank you.
Thank you.
Asha, shall I end the meeting? Asha, madam, shall I end the meeting for all?
Okay. So,
Sir, thank you, madam.
thank you.
I mean,
And
ending the meeting, madam.
thank you.